Good evening, everyone. Welcome to another session of PeMSAA Evening Talks. Today we have Dr. Sampath Herath, a proud alumnus of our faculty from the batch of 96-97, who will be talking to us on pediatric surgical emergencies. He is the consultant pediatric surgeon attached to National Hospital Kandy. So without taking much time, I will hand over the proceedings to Dr. Sampath Herath.
Right. First of all, thank you very much, PeMSAA and Kaushika, for inviting me for this kind of lectures for our medical students. Hope all are ready. Can I continue?
Yes, sir, we'll continue.
Yeah. Few things before starting. One thing is you can mute your mics while during the speech, and if you have come across any questions, just come to chat. So end of that subtopics, I will try to give the answer, and also just come up with your real name, rename your names, and then actually I can call by name that you have asked this question and all like that. Right. So our quick question, Kaushika, all the students are final students, aren't they?
Most of them are final years, and then there are some fourth years as well.
Yeah. So meanwhile, if there's any problem with hearing, my microphone, or you can't hear any anything, let me know. And
Sure, sir.
so we'll start the presentation now. Lecture. So I'm going to do pediatric surgical emergencies, common pediatric surgical emergencies that may be important for your exam and your career as an intern. And I specifically stress on non-traumatic, and trauma is a huge topic, and that has a lot of differences between adults and pediatrics. It's a different that need a one day for that. So I'm going to cover these topics: neonatal intestinal obstruction, other neonatal emergencies, incarcerated inguinal hernia that may be newborns or any other ages. Pediatric age, first of all, pediatric age is considered in Sri Lanka 0 to 14 years. And I would say before 0 also sometime we might have to involve, particularly fetal concern, fetal surgeries and all, so we might have to involve that. So it is, I would say, minus to 14. It might increase up to 16 in the future. And the other topic I'm going to explain acute scrotum, some other few important topics. And meanwhile, I'm happy to discuss any other interesting topic for you if you have any idea. So I'll start with the one case which happened last week. 32-year-old. Shall I give you 1 or 2 minutes to read this? Yeah. I would ask someone else to read this. This is in a real scenario, but low fidelity situation is the way I'm just talking to inanimate object. We try to be real. 32-year-old mother, P2C1, was referred to National Hospital Kandy with the antenatal detection of distended intestinal loop at 30 weeks of gestation in ultrasound scan. Hope you can understand this 30 weeks with the routine ultrasound scan of the pregnant mother. That radiographer, or sorry, radiologist had picked up the problem of newborn or the fetus distended intestine. It's unusual. She delivered a baby boy at 30 weeks, that is full term, and she was 7 kilos, and perinatal period was unusual. So what do you think? What we have to do now? Now, child is very stable, and so as a pediatric house officer, PHO, and you ask to answer this patient, and you do the routine neonatal examination, which is examining his respiratory distress, whether all the orifices are there, and any congenital anomalies or faces, and whether the child has passed urine, and getting whether the child is tolerating feeds and all, you just check. And particularly this kind of child, something may be there. Most of the time it is positive when the ultrasound scan is positive report. But sometimes actually you can't clearly say that it's definitely there are some problems. But we expect that was the reason actually we received to our tertiary care center. And we started with high fluid resuscitation, antibiotics, and warm the child, and send some bloods, and also get the consent if you found something in the for the investigation in future. And we put an NG tube and X-ray abdomen. X-ray abdomen is very important abdomen. If there's any, if you suspect any bowel pathology, an ultrasound scan is not much helpful, particularly when the gap. You all know that ultrasound wave cannot travel through air. Because of that reason, when the intestine is full of gases, you can't see. That is the main reason that we might know that when particularly if you want to examine the pelvis of a female with ultrasound scan, we have to send that patient to bladder. The bladder acts as a window into the pelvis, and all the waves can go through and come back to this media, and that is the picture. So that is the reason. And X-ray is very important, particularly this situation, particularly intestine, which is usually full with yeah. And the other important thing when you examine these kind of newborn, we suspect intestinal obstruction because some bowel pathology is there, ultrasonically something we found, and NG aspirate for the vomiting is very important. Anyone see that frothy aspirate or just frothy vomits? Well, that has some surgical clue. Frothy is that saliva, so that particular baby cannot swallow the saliva, so that's why saliva is coming as froth. So it happened in a very important surgical diagnosis in newborn, that is called tracheoesophageal fistula with the esophageal atresia. Right? You all know, as you do, pathology atresia is that particular part is not developed. Similarly, in esophageal atresia, part of the esophagus is not developed. There's no continuity. Newborn can't swallow the saliva because of that reason that just thought is coming. That thought can getting into the lungs and cause aspiration, right? And that is important. When you see this kind of newborn, just check that. And also milk. So just after the feed, baby just vomit out milk. So it may be reflux, particularly newborn, it is very common. 80% of newborn has got gastroesophageal reflux. Right? It is physiological. That's why actually we ask mothers to working because they excessive drinking. Some babies are very hungry and just go for milk quickly, and that will they will suck not only the milk and the young, altogether over distension of the stomach can cause reflux. This is very important. Green color vomiters. So that you would prove that intestinal obstruction is there. So green is coming from bile, and bile is draining to the duodenum. So if there's any obstruction beyond that level, so bile is come out from the mouth as a NG, aspirate, or as a vomiter. And when the obstruction is further down, not close to the ampulla, where the biliary duct is opening, so bile color can change due to the various pHs in the GI tract and also the organisms change into yellow. So that implies actually kind of a distal obstruction. So that keep in your mind. And when it is go further, particularly in adults, it is large bowel obstructions. So most of the time, just a dark yellow color vomiters or the English coming that is called fecal, that has a specific order like peaches. So that gives and give a clue that obstruction is further down, more close to the large bowel or distal ileum. Hope all are with me. And as I told you before, X-ray abdomen is very important. X-ray abdomen give us an idea where's the obstruction. So gas, usually we ask, when you do an investigations, we asking investigations, there are specific contrast we consider, particularly if you want to see the blood vessels and the blood flow and all, we give some IV contrast. So that give an idea, particular anatomy we can see. And when you consider bowel, we can give contrast. But actually, I would say in children's, gas act as a very good contrast. So what's the color gas comes? Anyone knows? In X-ray? Yeah, dark color, black. So this gas distribution pattern gives us an idea where's the obstruction. So very important clue. But actually, you have to, just after the delivery, you can't do these X-rays. At least you have to give 3-4 hours. Then only actually that gas can cover down and we can see. And that's why we have to instill sometime. Actually what I do actually, if you're in a hurry to go, the X-ray machine has come to the board altogether, actually, you can't wait until, you can't wait a couple of hours. I usually instill some air through the NG tube so that give maybe 10-15 minutes so that gas can travel down and you can see. Otherwise, actually, gas, that particular newborn should swallow the gas and that should go into the GI tract. That is why when you, this gas is important when you consider GI pathology, you might see that when you do the board round, particularly when you are in the surgical appointment, most of the surgeons are particular after the bowel surgery where the child, that particular position has passed platus, not the feces. So gas always should come from top. And feces, it may be in the GI tract, and due to the GI juices, feces can come. But if gas is coming from the bottom, that is later, so that implies that the bubbles are working and the system is better and continuity of the GI tract is there. So this is a newborn X-ray abdomen. So this is not our patient, it's a different one. So I just wanted to put this X-ray to show you that this is normal, right? So black color is here. You can see that this is a gastric bubble and this is the liver, and this is the subcutaneous fat, and also this is the intestine. This you can see larger one is large intestine, small size small intestines. So you can see this is evenly distributed. This kind of distribution of gas is normal, right? And if there's a referral from your PBU, say surgical referral saying there's a child with vomiting, when you see this X-ray, so you are safe. No, this is nothing. This is something medical. And there are few spaghetti-like things. These are, ECG connectors. This is I think, umbilical catheter, tube, and all. So this, keep this in your mind. This is a normal distribution of gas. What is this? So let's see the difference. Gas distribution is limited to upper abdomen, and which is denoted as two bubbles. The liver is there, one bubble, one bubble. So what's the diagnosis? You can chat anytime. You can have interactive sessions. Yeah, Pavita mentioned duodenal atresia. Yes, correct. Duodenal atresia, where the, as you know, atresia is just absent distal, or one of a piece is absent. And so this X-ray typical appearance is double bubble appearance for. This is called duodenal atresia. So what are these two bubbles? This is big bubble. It's not pyloric stenosis actually, because pyloric stenosis, you will see pyloric atresia newborn, you will see one bubble, right? So that, you got the answer that this is gastric bubble. This is duodenal bubble. So atresia usually happen in D2, usually proximal, distal to the ampulla, the second part of the duodenum. So this is the first and second piece of second part of the duodenum. This is the gastric bubble. So in between the pylorus. So this is a typical appearance of double bubble happen in duodenal atresia, and gas hasn't passed down at all. So it is complete obstruction, right? And sometimes you might see there are few gas bubbles here. It is partial obstruction, that is, and there may be a little membrane-like thing in the duodenum that has little holes, what is called a fenestrated diaphragm of the duodenum. So through that, actually, little bit of gas is passing down. So you can see little bit of gas bubbles around the other part of the abdomen. Clear? Next picture. Yeah, duodenal atresia. So what is this? So how many bubbles? 1, 2, 3, 4, maybe. Yeah, it is not definitely double bubble, isn't it? So huge distended bubbles, and no rest of the only few loops only. There are no further bubbles. Any guess? So this is called, just you can imagine, don't need any, you don't want any experience to say what this is. You can just think and guess what this is. And so the obstruction where? Yeah, where it is bit further, jejunal. So this is the stomach, this is the duodenum and few jejunal loops. So it is proximal jejunal obstruction. Most probably we tell actually jejunal atresia, particularly in this particular newborn. If this is the X-ray, this is jejunal atresia. So what is this? When it comes to this X-ray, you can see lot of bubble, gas shadows, but it is very different from this. Even though a lot of gas shadows are there, it is different from this. Sorry, this. It's not evenly distributed, just limited to few, numerous loops, and those are distended. So this is happening in more distal obstruction, maybe distal jejunal or idea, maybe jejunal atresia, ideal atresia. Right. So you can't see actually newborns that concertina pattern and frustrations in large bowels and concertina pattern in small bowel obstruction. But usually you can, once you get used to that, you can say this is not a large bowel, this is small bowel. This is definitely small bowel, If this is happening in large bowel, obstruction is large bowel, there should be more roots. So this happened in ideal atresia, one example. So this is our patient. This child, so we did X-ray and found to have two lobes. And this was, as you know, diagnosis is jejunal atresia. So the plan, so optimize the child and go for the atresia is just lack of non-development of jejunal level. But most important thing actually, we are not sure how far this has happened, how much of small bowel we have. So that is very important. That cannot be diagnosed actually with this X-ray because gas is not going down. You can't put gas from the bottom. So altogether you can't see. What should we do? All the newborns, as you know, started with ABCD. That's what we do in your exams. You start with ABCD. Make sure you know what is A, what is B, what is C, what is D. Some examiner might ask. Just like parrot actually, that's what we see, just mentioning this ABCD. So that's a very good thinking pattern, but make sure you know, right? And just put IV cannula. So what's the color of cannula we put for newborn? Anyone knows? Yellow color. And also we put umbilical line and make sure you are thorough with the cross section of the umbilical line. You have superiorly there's umbilical vein and there are two umbilical arteries. So you put into umbilical vein and we start IV antibiotic. This is definitely end up with the surgery and we start some IV fluids. So what is the fluid we start for newborn? N/5. And that is the only indication for N/5 saline, and rest of the kids actually do normal saline or they just normal saline or N/2. And N/5 is banned in overseas countries, most of the developed countries, because that causes a lot of problems if you give, just like you are giving water. And this is just for newborns. And warming, for that we insulate and put into the incubator. So that's very important. And newborn can lose a lot of heats, and they might go into hypothermia. And if this happen in district hospital or base hospital, this baby should transfer to a tertiary care center. So how do you do that? So inform the parents that we are going to send, and also you inform the receiving end, give a call and get the instruction from them and how to transfer, and make sure that beds are available, particularly if the baby is coming to a PBU. You can't shoot that baby here. So you make sure that bed is available, and always discuss and get the instruction from the receiving end and transfer the patient. Particularly, you can transfer with the mother. So that is the best way of transfer. And if child is very unstable, you might have to transfer by neonatal incubators or neonatal bullets kind of transfer method. And so also arrange the consent if the mother is not coming with the baby. If particularly after cesarean section, you can transfer the mother. In that case, arrange the consent and possible consent, laparotomy consent, and bowel resection, anastomosis, stoma, and just get the input from the receiving end or receiving surgeons, and just get the consent broadly. And avoid dehydration with IV fluid, and because it may be a long journey, and the baby may be coming from Mulatiw to Kandy, so it might take 4 or 5 hours. So make sure that hydration is going on, and hypothermia, similarly hyperglycemia. So this particular baby in the laparotomy. So this is what we found. So what is this distended part? So this is a jejunal loop. So baby is there. This is not just bowel, baby is there. And incision is somewhere here. We took the intestine out. And not like in adults, what you see in the operation theaters in adult surgery, you can see the big body and everything is happening inside. But newborns, actually we do everything outside. You can exteriorize almost all organs and do it, right? And this is the proximal end. This is the distal end. This is the distended jejunal loop, and duodenum stomach is inside. And this is a little streak-like thing, band-like thing. This is a distal small bowel, right? What we do is actually just divide from here and divide from here and just join together, easy. And make sure no associated atresia in further. You still some saline until it come out from the anus, and after that join together, right? Okay, I don't want to go further how to manage after the surgery and all, right? And we were talking about the atresia, that particular case. With that, actually build up some other scenarios or the situations that cause intestinal obstruction in newborn. Midgut malrotation and volvulus. Have you heard about this? Midgut malrotation and volvulus. Right. So very important diagnosis. Just forget about everything what you are going to learn today, and just keep this in your mind. So that will save a baby one day, right? When you learn embryology, you might learn that intestine herniate out when it develops, and when it's coming back, it will come, cecum come first, and lie in a particular manner. That is normal rotations, and malrotation is abnormal way. It's rotated, and intestines are lying in a different manner, right? So that can cause into twist, what is called volvulus. It's a pediatric emergency. There are two real pediatric surgical emergencies. One thing is this midgut malrotation and volvulus. The other one is um, testicular torsion or testicular twist. More or less same, that vascular events happen in non-traumatic vascular events happening in children's midgut volvulus and the testicular torsion or testicular volvulus. You can tell like that also. I never heard like that. This happen when you, particularly this baby is presented to you with bilious vomiting. If you see a baby with bilious vomiting, don't disregard these babies. 1/3 of bilious vomiters end up with this volvulus or malrotation, right? So until proven otherwise, you have to exclude malrotation and volvulus. And 90% of these midgut malrotations present as volvulus in first month of age, and rest, even rarely in adults also, they can present as volvulus of the midgut, not the volvulus of the sigmoid colon, right? It's not the siggy volvulus, right? It is midgut volvulus. If not timely intervened, volvulus is twist, so that definitely compromise the cut off the blood supply. So time is really matters. If you don't intervene timely, what will happen? Whole midgut will die. So yeah, it starts. Where the midgut starts, which is supplied by superior mesenteric artery. So where it starts? Midgut, anyone knows? Started from second part of the duodenum and end up at transverse colon. So whole intestine will die and life is incompatible after that. So very important diagnosis. So they present with you bilious vomiting. Right? There's a question actually saying, is it normal to 5 days baby fast foods 10 times a day? Yeah, it's normal. You have a baby? Yeah, that's normal. And that's when it reduces with the time. And 10 times when it is coming into 1 month, it is going to be 5 times, just like that. When it is coming into 1 year, so it's going to be 1 time daily. So this is the some pictures describing malrotation. This is the normal rotations. After the normal rotation, that intestine lies, that cecum, like that. And also this is the pylorus coming like that, making a nice C, and DJ flexure is here. So if you take midline here, so DJ flexure lies at the pyloric level with the DJ flexure, and also posterior to the stomach, and it's left side of the abdomen. Right? They start like that. Superior mesenteric artery is coming like that. This is the mesentery. It's coming like that, nicely lined. So when it is into the malrotation, this is one variation of malrotations, and it's coming like that. And this is the pylorus, and this is the DJ flexure line. It should have been here. It's here. And small superior mesenteric vessels are coming like that, right? It is not, mesentery is very short, like that. Then cecum is just pendulous. And what will happen? So this is the situation that can go into volvulus, just twist. It's happening like that. So this is where it twist. Yeah, twist. And hope you can see me. right? And so what shall we do for this? So we were talking about the malrotation and volvulus. So definitely child need a surgery. Middle of night, this baby diagnosed as volvulus. You can't wait till tomorrow morning. So we have only few hours. Otherwise, baby's whole intestine will die, right? And so need an urgent operation. This procedure is called lag procedure. And you don't have any time to optimize child. Just go to the theater and open. And what shall we do? Just untwist first. And division of the disease lattice band. This is called there are some cecum crossing into the some bands crossing from cecum into the retroperitoneum in the liver area. Those are called lattice band. Just division of the lattice band. And then you cockerize the duodenum and broaden the mesentery and keep this in position, right? So make sure that this is wider. You can't put into this normal position. So what we do is actually just broaden here. Still the malrotated position. The duodenum is nicely coming like that and going like that. There's no, this is wider, this will not twist, right? So when you put the intestine, you put the small bowel into the right side, large bowel into the left side. So routinely we do the appendicectomy because actually, in future, appendix is in the left side. So in that case, we might misdiagnose the appendicitis. So that's a very common diagnosis in childhood. And just to prevent confusion, we do the prophylactic appendicectomy. And the other diagnosis is infantile hypertrophic pyloric stenosis. This is not newborn diagnosis. This is not a newborn intestinal obstruction. This is happening in infants, right? So what is happening in newborn is pyloric stenosis. So it's very rare. Most of you will never see in your career pyloric stenosis, and I have seen only two. And just like the very rare situation, pyloric stenosis, right? So what we are talking is infantile hypertrophic pyloric. It is very pyloric stenosis, or also called pyloric stenosis commonly, right? So this is very common, and particularly common in Caucasian countries, developers, and so people refer it is due to too much formula drink. They avoid breast milk feeding, and it's very common. These figures actually their figures, 3 to 5% thousand live births, and it is a bit rare in our part of the world. We don't know exact reason, but it is not common. And commonly 3 to 5 weeks of age, start from 3 weeks to 5 weeks, might extend it up to 8 to 10 weeks, very rarely after 12 weeks, right? So that gives an idea what will happen if you don't do anything for pyloric stenosis. In case if child lives with this obstruction, so it will settle itself, right? But the thing is actually that during that particular few weeks, actually child needs some feeding. So that cannot be pop up. That's why actually child needs an intervention, right? Otherwise, that's why we very rare to see these pyloric stenosis after 12 weeks, right? Whatever the things come, disappear. It's on, right? And it is the hypertrophy of the pyloric muscles. I'll show you in next slides actually some diagrams where pylorus is hypertrophy. Common in males, particularly firstborn male. That was a common saying in good old days, and present as projectile non-bilious vomiting. Maybe it's just non-bilious. The bile is not coming into the stomach. Reason is the pylorus is blocked, and particularly late presentations, they can present with weight loss, Hippocratic phases where all the sunken eyes and dehydrated skin turgor loss and metabolic derangement with that low urine output, respiratory difficulties due to metabolic derangement is due to particularly acid loss from the gastric acid, so they will get. But metabolic alkalosis, when you are using HCl from your stomach, due to repeated vomiting, you will end up with metabolic alkalosis, right? And how do you diagnose? So clinically, you might palpate pylorus. Particularly, there's a way of palpating when you palpating pylorus, particularly in phyloiric stenosis. You can see in YouTube. I haven't uploaded into these presentations, and particularly when you examine the midline and the liver border area, that angle, you can feel it. While child is well settled, you can see. Particularly these babies are very irritable because they are hungry. They are not sick, but they drink and vomit. Again, they are hungry. So because of that, they are very irritable, very difficult to examine. Best thing is to examine these babies while feeding. And you can see just like olive-like thing in that particular triangle area, right? And but nowadays we diagnose this ultrasound scan. When you do an ultrasound scan, most of the radiologists can diagnose phyloid stenosis. It is usually finding the figures, dimension of the pylorus, muscle thickness more than 4 millimeters, and the length of the pylorus is more than 18 millimeters is diagnostic of pyloric hypertrophy, right? Rarely we might have to do some contrast studies to see, but most of the time ultrasound scan is diagnostic. That's why actually, because of we do as ultrasound scan is what kind of investigation, it is very subjective and also non-invasive. With that actually, frequently practitioner asks ultrasound scan. So because of that reason, actually, most of the pyloric stenosis diagnosed very early. We rarely see these delayed presentation of pyloric stenosis. Very rare to see. So what do you do? So what child need an operations where we basically vertically, longitudinally divide the muscles of the pylorus while keeping the mucosa intact. So that will relieve the obstruction. So that is for Ramstead pyloromyotomy, which was the surgery described more than 80 years ago, and that still we practice that procedure that has a 100% cure and 0% mortality and morbidity. I would say mortality. And with that, actually, nobody want to find any other method to cure this problem other than this pyloromyotomy. But some Japanese describe doing some Botox endoscopically and putting a transpyloric tube and feed until it settles its own. Different methods are there, but this is the gold standard treatment. So this is the pylorus cross section that has a thick muscle, and so we basically split. So that can be done laparoscopically, newborn or the infants or open technique, and nowadays laparoscopy is popular, and basically we cut like that with the diathermy and split. So you can see that mucosa is bulging out. So it's a promising surgery actually. Just after the surgery, after recovery, you can start the feed. And there are a lot of protocols in overseas actually days. After the 3 tolerating feeds, you can discharge same. Sometimes some people practice as a day surgery, but at least overnight we try to keep. Sometimes our babies are struggling to tolerate feeds even after surgery. The other intestinal obstructions happening in newborns are esophageal atresia. That's what I discussed you actually. You know, they have 40 vomiting, and pyloric atresia, as somebody said, actually very rare. And duodenal atresia and small intestinal atresia. I'm not going to discuss and everything is going to be very important lecture, particularly distant teaching this, you know, you can find this one actually, and there are different types and how to manage and all. But you are welcome anytime actually to my ward rounds. You can see most of these cases frequently, and that is candy wall 63 and 70. And principle of treatment, whatever the obstruction, try to make the continuity of the intestine. Does esophageal atresia just join the two ends of the esophagus, divide the tracheoesophageal fistula and join into each other, and similarly pyloric, and we do the bypass, gastrojejunostomy, and also duodenostomy. Small intestine atresia, we do jejunostomy, ileostomy, like that. And the other thing is hindgut problem. That may be an rectal malformation where imperforated anus usually we call, and so that need a colostomy and do the stage repair and similar thing. And large intestine, they can have, those babies may be having what is called Hirschsprung disease. I'm not going into detail what is Hirschsprung disease. Hirschsprung disease is a disease where the pathological hallmark is loss of ganglion cells in the both myotic and meniscus plexus, and because of that, those absent ganglion segments are not moving, so they spastic, and rest of the intestine, normal intestine, get distended. Almost always rectum is affected. So Hirschsprung disease starting from rectum to upward. So that may be rectal sigmoid, that may be extending into the large bowel, rest of the large bowel and all, right? So you might lean, if you get a chance, actually in future we can discuss those diseases separately. Otherwise it's going to be bored. I can talk and talk, and you might just sleep probably after a heavy meal. And the duplication, that is two bowel tubes are there, so one can get blocked just like that. And meconium ileus, where the meconium is very thick, that's happening in cystic fibrosis, that can plug the intestine, and that can anatomically block the intestine. So those are the other possible diagnoses when it comes to newborn intestinal obstruction. Any questions? Some point to stop intestinal, newborn intestinal, pediatric intestinal obstruction at that level. We'll move into a different topic. I give 2 minutes for asking a question regarding that. You can ask any time.
So far, they haven't typed in any questions. So we can move on.
Yes. Yes. Probably. Hope they are not sleepy. Yeah. I'm not sure actually how this works, but this is the way we have to go forward. Anti-Kaushal. So this is the way we have to go forward,
Yes,
We are not
yes.
sure.
These days, everything is
Yeah,
completely
everything
blended.
stuck, and we will end up with this. And yeah, it's about a diaphragmatic hernia. I'm going to discuss in future. I'll let you know. And IV antibiotics given prophylactically, sir? Yes, and it is a surgical topic actually. Um, Prophylactic antibiotic, yes. This is actually as a prophylaxis. Yes. And usually these surgeries, because after feeding only these babies, intestinal effluent is get colonized with bacteria. Otherwise, actually sterile. But particularly when you do a surgery on a newborn, um, uh, newborn, they are vulnerable for infection. The immunity is low because of that reason. Actually, we do antibiotics. Otherwise, more or less, those are clean surgery. And neonate with BP less than 60 and mother was given pethidine during delivery within 4 hours. What is the best management of this child? It looks like child has got some opioids, and with that, yeah, exactly. Child needs some airways. Most of the time with the airway airway opening and some mask and oxygens will settle the thing. Otherwise, you might have to do some naloxone. And yeah, definitely. There's another question saying that transit pyromyotomy, is there risk of perforation? Exactly. There's a risk of perforation is there. And that's why actually, particularly in experience and when we do the laparoscopic, actually you might make a hole. In that case, actually we one thing is just keep the NG tube couple of days, it will heal its own, or it's actually just suture that perforation, or the repair the perforation, or else actually repair everything and do the Ramstead myotomy, pyromyotomy in a different place, 90 degrees away from the original side. Just like that, you can do different techniques are there. Most of the time, laparoscopically, when you do, we'll be more careful, and most of the time we don't do complete division of the muscle rather than perforate. So what is called, it's not real recurrence, but inadequate division is the problem. And yes, yeah. Yeah, let's move into the other topic. Next topic. Yeah, abdominal wall defect. Right. So that is also another important emergency happening in pediatric age, newborns, and you might come across actually the situation that baby's intestine just outside, or you can see that there's a bubble-like thing in the umbilical area. So you see through that membrane, you can see the intestine inside or the liver inside. So just like that. So the abdominal wall defect. In addition to that, sometimes rarely heart may be beating outside. Different things are there. But I try to limit my speech into two major diagnoses. Those are the two common things. And gastroparesis and omphalocele. So what is gastroparesis? What is omphalocele? So I put a picture actually. So this is when you see intestine like that, when baby born, intestine outside. You can see the intestine, no covering. Here actually intestines covered with the little membrane, amniotic membrane. You can see through that, and you can see actually umbilicus is coming like that. Umbilical cord is coming like that. And here actually umbilical you can see, and the intestine is coming out from the defect just next to the umbilicus, right? and this is gastroparesis. This should come here, and omphalocele come here, right? And so in your level, actually just know the differences. That is a common question you might ask in your MCQs. Gastroparesis, omphalocele covered with membrane. But sometime actually what will happen, this membrane, particularly normal delivery, can break. So intestine may be like that, right? But most of the time covered with membrane, whereas gastroparesis not covered. So intestine, there's a abdominal wall defect next to the usually right side of the umbilical cord, and through that intestine come out, right? Here the intestine just exposed to the amniotic fluid and intestines are macerated. Here actually intestines are fine, not edema, right? Right, that's what I told you. And associated syndrome, common in omphalocele, right? So syndromic babies, particularly when you see the face, actually those babies may be syndromic, but particularly they have big mouth and tongue is outside, and what is called Beck-Wiedemann syndrome, and different syndromes are associated with omphalocele, whereas actually less likely to associate syndrome with this condition, what is called gastroparesis, right? And but there's a problem in gastroparesis where GI atresia, I mentioned you atresia, it's common in gastroparesis, whereas omphalocele, intestinal atresia unlikely, less likely I would say. And these babies are, these omphalocele babies are well grown, they are big, and usually term babies, and no IUDR, and whereas gastroparesis babies are, they are small and preterm delivery, sometime IUDR, and particularly young mothers with some drug abuse, they can have those situations. These babies, reason for this abdominal wall defect development in gastroparesis is some ischemic event happen intrauterine life while abdominal wall develops. So what do you do? How do you do? You know, you can't keep intestine outside like that. Particularly, this situation is not at a risk actually, because anyway, intestine covered with this membrane, right? And there's no any hurry to put it back and close and everything. But here, yeah, this is a real emergency, right? So what shall we do, right? Particularly, until we put this intestine into that and cover the tummy, across the tummy, and we have to do something. Just follow the, as I discussed, all the common thing we have to do for newborn, just follow IV access in the tube and good hydration and avoid hypothermia, just continue. And this specific situation where abdominal wall defect is there, we have to cover this intestine until we, particularly this situation, until we until we operate this baby, right? And one thing is you can put this into a bag. What we commonly see is, a lot of practitioners just cover with wet saline gauze and plasters and all. What will happen when you put wet? So baby will develop hypothermia, losing a lot of weight. And at the same time, saline also take some heat out, and that actually hypothermia is issue. At the same time, lot of evaporation of the fluid that results in hypovolemia. So what we recommend is cover with a plastic sheet. So what I do is actually take lunch sheet and just wipe with some betadine and cover with this. Just cover. And after that, put some dry gauze, and so that will insulate the baby and transfer the baby to the special care unit, right? So we tend to keep this baby in this position, right, lateral position, because mesentery is like that. So twisting of this intestine is minimal when you keep like that. Whereas if you are trying to keep these babies in supine position, what will happen? So this intestine fall into one side, and that can sting the vessels, and ischemic insult can happen to this intestine, right? This baby is also the same. You can keep lateral, or else actually what we can eat this baby in the incubator. You can just hang, take the umbilical cord and just hang on to the roof of the incubator. So it will be like that, right? And we take this baby into the theater. Sometimes we might have to do a stage closure with put into a bag and close it later, or else direct closure. Right. I'm not going into discuss the surgical operative management and all, just basic stuff. Any question about abdominal wall defect? If you have seen, how many of you seen? Any questions? 1 minute I will give, but you can ask any time these related question for any topic. When I get a chance, I'll answer. Okay, we'll move into the next topic. Respiratory distress in newborn. This is a very important topic in pediatrics actually, right? So when we do pediatric appointments, 1001 causes are there for respiratory distress in pediatrics, particularly newborn, and again actually AR newborn distress syndrome and wet lung, different reasons are there. And when it is coming to childhood, actually there are again actually asthma and allergies, corona, different diagnoses are there. But when it comes to newborn, and there are only few surgical diagnoses, and you will be referred these patients with the proper diagnosis most of the time, right? And yeah, there's a questions about the previous topic. How many hours can we put outside the bowels in gastroparesis? There's no any hard and fast rule regarding that. Actually, once the baby is delivered, best thing is to, you can keep, sometime actually gastroparesis and liver is outside. In that case, actually, you can't put there's no any room for intestine and the liver inside the abdomen. So in that case, actually, it might take actually days and days, sometimes few weeks also. We put into a bag called silo bags. That is the silicone bag, and just like in, just assuming this is a bag, like that, actually we keep like that. And we close it stage-wise until we wait until, you can't just put it that, what will happen is child will go into respiratory distress. And we might move into the other topics like that. And so surgical causes are diaphragmatic hernia and diaphragmatic eventration, pneumothorax, particularly how pneumothorax happen in newborn. Particularly, they have grunting and respiratory difficulties due to some other reasons, maybe wet lung, over enthusiastic, doctor will, ambu the baby and, with the positive pressure. With that, actually, sometimes these lungs can rupture, and that results in tension pneumothorax. And sometimes space-occupied lesion, what is called adenomatoid cystic malformation, those can present as respiratory distress. Because it is actually, that newborn is the one actually, that is where that particular period actually that child, baby, while baby intrauterine. So baby's oxygen is depending on coming to the placenta and the cord. And this is where that transition happen into lungs. And, then only baby can maybe symptomatic. There may be baby might be having a huge mass in the thorax, but fetus is asymptomatic because of that mass. Baby is not symptomatic because baby is getting oxygen from the mother, and this just after delivery only baby get symptomatic. That is a very important transition period. So, but I will limit my topic to diaphragmatic hernia. So, this is the child actually I operated today, and day 0, this baby born day before yesterday, uneventful antenatal history. They did ultrasound scan, what is called anomalous scan, normal, and male infant delivered vaginally, and luckily mother came into Kandy hospital, and without delivering in the local hospital, and dual of respiratory distress just after the birth. And this newborn was resuscitated and intubated, and just after the intubation, saturation picked up, and for that actually baby was on 100% oxygen, and baby needed some 2 inner probes with that very unstable baby, and baby was resuscitated in the NICU for 2 days, right? After that, actually, baby's condition, meanwhile, actually, we did some investigations to find out what's going on, and this was the X-ray. Can you see what is this X-ray? Any comments? I'll give 1 minute. Hope all can see clearly. Any comments about this X-ray? At least comment about the abdomen. What's happening in the abdomen? This was done actually a few hours later, after the delivery. But baby was intubated few hours after the, or maybe 1 hour after the delivery. Diagnosis in diaphragmatic ventration. Yeah, abdomen does not have bowel shadows. Yeah, no bowel shadows. That does not mean there's no any bowel in the abdomen, but it is a gasless abdomen, isn't it? Right? But there are some bowel-like structures in the where? Thorax, left hemithorax. Lung damage. This one, yeah, sometimes lung pathology appears like that. But when you see no intestine, some intestine-like shadows are in the thorax, we can assume that intestine is moving into the, developing the thorax or moved into thorax, right? So this is a typical case of diaphragmatic hernia, right? Diaphragmatic eventration, what is happening is a paralyzed intestine, paralyzed hemidiaphragm. You can see diaphragmatic margin like that, eventration, right? So this is diaphragmatic hernia, right? All the intestine is like that here, right? So what is this line? I told you in the first X-ray abdomen. What is this? Tube. Anyone knows? So what has happened to the heart? Heart has moved into the right side. Because of this hernia, it has moved into right side. Right? This line. So this is the umbilical catheter. So usually umbilical catheter should go this way. This has to go into this way. Why? Even liver also goes as you. A piece of the left lobe of the liver has gone into the thorax. Right? So I don't have the intraoperative pictures. And basically all the intestine, stomach, spleen, left lobe of the liver, large bowel, everything was inside, right? So this is, as somebody said, actually no bowels in the abdomen. So I had to put back everything in and repair the defect, right? And luckily there were enough room inside, and maybe struggling with the respiration and all, right? And diaphragmatic hernia. So this is called congenital diaphragmatic hernia, and there are in the other things happening in adults is the traumatic diaphragmatic hernia or adult onset. And congenital diaphragmatic hernia is a developmental problem. And when you learn embryology, I don't want to go into details. You know, there are a lot of 5 things involved for diaphragmatic development, and the failure of those things results in diaphragmatic hernia. There are 2 types. One thing is anterior diaphragmatic hernia and posterior or posterolateral diaphragmatic hernia, right? Common one is posterolateral diaphragmatic hernia. The left side is the most common part and most common one, and the, that is the commonest, and it is called Bocardal leg hernia, and so that's what happened to our child also. I would say 90% of the diaphragmatic hernias are left posterolateral, then the right posterolateral, after that anterior diaphragmatic hernia, right? Severity of and the disease severity and the outcome after the surgery all depending on, just want to remove that, and sorry, actually it's covered with this picture, and it is actually pulmonary hypertension. Pulmonary hypertension and lung hypoplasia are the hallmark of pathology of this, right? And severity and the outcome all depend on pulmonary hypertension, lung hypoplasia, right? So as someone asked me in our chat, actually diaphragmatic hernia is a surgical emergency. No, it is not a surgical emergency. You know, the old teaching was actually, you know, hernia is there. That is a problem for spotting of these lungs. What you have to do is just go and reduce it and close it. That was the old teaching, and most of the babies die actually after the surgery. And because this happened actually in right, just because pushing this thing down will not improve these lungs. And this pulmonary hypertension is due to the vascular problem in the vascularity of the pulmonary vessels, not only this side, also in the right side also. So pulmonary hypertension control and the resuscitation of these babies with pressure support are the most important. That's why actually I operated this child after 48 hours, right? Initially the child, the oxygen requirement was 100% oxygen, FiO2 was 100%, and child was on 2 iron drops. So I had to wait 2 days to wean the baby from this sad situation. And so our markers are FiO2, that oxygen what we are giving is reduced up to 40, and the minimal iron drops, urine output is good, then only we decide on the surgery, right? So sometimes, very rarely actually, the one diaphragmatic hernia newborn baby was very unstable, and I had to wait more than 1 week. I can't do that surgery in the operation theater. I had to go to the ICU and do the surgery because child is so unstable. I couldn't do the surgery. Child was on kind of a ventilator called high frequency ventilator, oscillating ventilator. You can't move those babies out of the ICU. So I had to do the surgery while baby was on oscillating ventilator. And so it is not an surgical emergency. It is a physiological or medical emergency. I would say physiological, it's not medical. Yeah. And there's another question saying, yeah, it takes time. You know, we do pneumonectomies and sometimes you might resect the one part of the lobe and all. So with that actually, you know, the rest of the lungs develops and take over the function. Similarly, actually, most of the diaphragmatic hernia, they have a hypoplastic lung. Those hypoplastic lung develop into a certain extent, right? And but most of the time actually their development get normal and their exercise tolerance is normal. It doesn't matter actually whether you have two lungs or one lungs, as far as that particular person in adult life, you know, exercise tolerance is normal, they can have normal happy life with hiking and tolerate low partial pressure of oxygen in Masha before Everest, you know, that's fine. And most of them, they can do those activities. But because of the initial hypoxia, they can have some learning disabilities because of the hypoxic insult to the brain. And there are some papers, they say that there's a particularly severe diaphragmatic hernia, just like the one we did today, and they might have, you know, can have some hypoxic insult because their saturation was low, very low actually just after the birth, and after the surgery also child went into what is called pulmonary hypertension crisis. That actually you lost the, you know, whole body is going to hypoxia, and with that actually some damage can happen to the brain. But otherwise actually their exercise tolerance as an adult is normal. What shall we do? Resuscitation, that is very important. Ventilation, fluid and circulation, control of pulmonary hypertension, and after that, once baby is optimized, that is, we get the set requirement and blood gas okay, and the saturation is fine, minimal iron drops, good urine output, that implies very stable baby. Sorry, we'll go for the surgery, right? That is actually basically pull the all the thoracic organ, intestine into the tummy and just close the defect. Sometimes just direct closure, sometimes might have to put a patch into the diaphragm. So previously we had just a direct repair. Any questions regarding diaphragmatic hernia? So I'm just superficially going through, and just to make this discussion interesting, I don't want me to go into the you know, minor details such as antenatal diagnosis, antenatal interventions, fetal surgeries for diaphragmatic hernia, and all. And I'm just limiting to those superficial things. Shall we move into the next topic? Inguinal hernia. Inguinal hernia per se is not emergency. When it is incarcerated, what is called get irreducible. Incarceration equal irreducible, right? That's an emergency, right? You know what kind of hernia we see in pediatrics, right? Inguinal hernia. What kind of inguinal hernia? Almost always. Yeah, one answer is coming. Indirect inguinal, correct, right? So that is actually patent processus vaginalis, where the patent processus vaginalis, where the intestine is coming out, whereas direct inguinal hernia, just the posterior inguinal wall. Okay. Yeah, correct, right, and right. So younger the age, higher the chance of incarceration. That's why actually When the newborn presented to you with the inguinal hernia, next week or next available week, we try to do the surgery. Because it will not settle its own, so you have to repair it. Or not repair, herniatomy, right? And basically tying off the patent processus vaginalis, right? And I'll show you a picture. This is the one. So push it there and just close it. While so they present as excessive crying, inguinal scrotal lump, sometimes obstructive features, vomiting, and examination you might find a tending inguinal lump or scrotal lump, and differential diagnoses are sometimes cyst of the cord or canal of the neck, and cyst of the canal of the neck in female, and lymph nodes. Those are the possible differential diagnoses. And what shall we do? Incarcerating when it's an emergency, need the urgent admission, and pain relief with sometime, give some Panadol suppository, and or give some IV Panadol, and give some opioids, subcut morphine, and careful when you give subcut morphine for newborn, they can go for apnea. And manual reduction, that is where actually specifically there's a special procedure where we push the hernia in. We don't practice in adults these things, and I would say 90% is successful. Incarcerated inguinal hernia you can reduce, and basically there's a special technique I try to find in YouTube, actually I couldn't find any video clip to upload you. And I should do a video clip and upload, I suppose. And it is a very good, very important procedure we, as a pediatric clinician, we all should know. And we should know how to reduce this incarcerated inguinal hernia, right? After that, we'll go for the surgery. So surgery is basically this inguinal hernia, basically we reduce it and also separate these vas and vessels out of this processus vaginalis. And so this is the processus vaginalis, thin bag-like thing. The one end, the other end is in the scrotum. This side is the penis and scrotum is there. We have divided there. And this is the patent processus vaginalis where the hernia comes. We just tie here. Carefully we separate vas and the vessel. Otherwise end up with the atrophy of this testis, and close it. So that is herniatomy. Right. Let's quickly move into the next topic. Acute scrotum, very common question you might get in your final years. And what is acute scrotum? Boy presented to you with sudden onset of scrotal pain, right? So what's the problem with sudden onset of scrotal pain? Sometimes they might come as, there may be some trauma, he was cycling, suddenly got the pain and all. They might refer into some traumatic event, but most important diagnosis is torsion of the testis, twisting of the testis. That is the, after malrotation and volvular, this is the second real emergency, right? This organ-threatening emergency, right? And this should be considered seriously. Otherwise, again, time matters. Otherwise, you might use the one testis. What will happen if you lose one testis? Nothing will happen actually. It's we have two, and with that, just one is enough for become a father, and there may be a fertility issue, but the chance of become a father is 100%. And but if it is bilateral, definitely you might do that. And other possibilities are when a child presented to you with acute scrotum, torsion of the appendix of the testis and epididymis. Appendix of the epididymis. There are little knuckles like parts in the appendix of the testis and the epididymis of the testis, or testis and the epididymis. Those actually vestigial parts of um, uh, gonadal developments, particularly female gonadal parts, and those can twist and present as acute scrotum. And epididymitis or otitis, they can have infections, particularly if they have some anatomical problems that lead into recurrent UTIs, that they can present as epididymoitis. Trauma, sometimes tumor, they can come as tumor complication, bleeding into tumors, particularly germ cell tumors in babies, and sometimes scrotal problems. They can have insect bites and some infection or folliculitis of the scrotal skin. And the other thing is idiopathic scrotal swelling. It is a diagnosis where just everything swollen, minimal tender, but everything is scary, way swollen. So this is a torsion testis. How do you diagnose? It is a clinical diagnosis. Time matters. You don't do ultrasound scan. It is very painful. Can you do ultrasound scan of a scrotum when it is painful? It's very difficult. Ultrasonically you can see that, if the child is sedated, you can see that no blood supply to the particular testis, no Doppler flow. But everywhere, all the pediatric surgical centers, everywhere recommend don't delay for ultrasound scan, right? Any clinical suspicions, go and explore, right? Time matters. Don't think about the fasting. Obviously, if child presented to you after 24 hours, you can wait for 6 hours fasting, because probably child lost the testis, right? Otherwise, actually, we have to explore as soon as possible. So this is a picture, unfortunate situation where testis is necrosed. You can see twisted testis. So it happened like that. Why these testis twist? It is due to there are some testis, their tunica vaginalis. Tunica vaginalis is completely not covered at all, right? Usually when you learn anatomy, actually this posterior epididymis is tunica vaginalis attached. So only this part is just a sac-like thing there. But whereas actually what is called this particular situation where tunica vaginalis is not attached to the testis at all. So it is just hanging testis inside a cavity. So easily it can get twisted. What is called bell clapper deformity. Bell in the clapper, just like that. So this is the normal way. So this is that particular deformity, bell clapper deformity, where that just testis is not, tunica is not attached to the testis, just inside the cavity. This blue line is the cavity, just hanging. So that can twist. Usually this 70% bilateral chance is there. That's why actually when you explore, if there's any twist, so we untwist and fix this to 3 stitches, not to twist further, and at the same time we explore the other side and fix. Because of risk of bilateral, because of chance of bilateral bell clapper deformity. Prepare for immediate exploration, consent for pedectomy, and fixation of opposite side. Those are the things, principles we do in testicular exploration, right? So those are the common pediatric surgical emergencies I just wanted to discuss with you. And if there's any further, there are a lot of pediatric traumatic and atraumatic emergencies in pediatric surgery, and some more to learn and all. But I hope this is interesting initiation for your curiosity for pediatric surgery. But you are always welcome for my ward, and you come for a ward class and all, or join the ward round. And when you start your clinicals, and you can send if there's any questions to any questions to my WhatsApp or Viber. This is my number. And you can WhatsApp me. This number I can answer. And, there are a few questions actually. Yeah, there's a one question say that can diaphragmatic pleura defect leads to develop diaphragmatic hernia? That can happen in trauma, but what is called the hiatus hernia, or sometimes congenital hiatus hernia, and that is hernia is coming through the hiatus. And pleural defect actually, that is trauma, probably trauma or surgery after surgery that can happen. Those are not congenital diaphragmatic hernia, right? And the other one is suction contraindicated in newborn suctions. Resuscitation, not really actually. There's a way of sucking the suck out the secretion newborn, and you use actually minimal suctions, and at the same time maybe minus 5 centimeter water like that. Actually suction pressures be applied, and you close the tube and put it in and suck out the things. Not contraindicated. Herniorrhaphy is the repair of the, there are two things actually for the hernia. One thing is the herniatomy and the herniorrhaphy. Herniorrhaphy, when you see the anatomy, actually, herniorrhaphy is for the direct inguinal hernia, and where the posterior wall of the inguinal canal is weak. But whereas in children, it is indirect inguinal hernia, it is a patent processus vaginalis. We just close it. It is called herniatomy. But particularly this indirect inguinal hernia, that is childhood inguinal hernia coming in adolescent, particularly 18-year-old adults coming like that, actually we tend to do the herniorrhaphy also, because possible direct inguinal hernia in future, we do the herniatomy and herniorrhaphy those together. I hope it's adult practice actually. That was a practice when I was a trainee. And what do you think, Kaushika? Do you think that particularly 20-year-old male coming with the indirect inguinal hernia, do you do just herniatomy, or do you do herniorrhaphy also?
No, in adults we do the herniatomy and we put a mesh to.
Yeah, that's the thing. Both we do, but
posterior one.
Yeah, pediatric actually we do herniatomy only. Yes, and do we do ophidectomy in all patients who has testicular torsion, even the testis is viable? No, not at all actually. We try to preserve the, oh my God, it's a crime, just cutting a ball out. So usually what we do is actually we unpist and put warm saline and wait. There's, nowadays actually we tend to keep dead testis also in the scrotum because of litigation issues. And most of the time, we wait, and sometimes make incision in the testis, whether the blood supply is there. Any doubt, we try to keep the testis. We can go and explore later if there's an infection. But definitely we fix the opposite side because of the risk of bell clapper in the other side. Diaphragmatic hernia may stomach can involve alone. Stomach can go, And most of the time, actually, it will not end up at stomach level, but particularly in the eventration, where actually weak diaphragmatic hemidiaphragm due to maybe Erb's faults, what is called the birth injury to the neck, phrenic that can result in paralyzed hemidiaphragm. That can cause actually kind of a stomach herniate into the thorax-like picture, that kind of volvulus of the stomach. What are the reasons for sudden deterioration of premature child while being ventilation? Can it be due to persistent pulmonary hypertension? If it is a diaphragmatic, more possible thing is because of the ventilation, actually positive pressure, you develop a tension pneumothorax. That is a common situation. So just put a needle and needle thoracocentesis and see whether it is improving, and or just do the chest strain or chest X-ray if time allows and see. Other possibilities are, as you mentioned, pulmonary hypertension also can cause this situation. This pulmonary hypertension will settle with the time, but sometime actually that can aggravate what is called pulmonary hypertension crisis. Pulmonary crisis, those babies can go into pulmonary crisis due to various reasons, maybe hypothermia, maybe cannulation and pain, and those things can go into sudden spasm of the pulmonary vasculature and go into pulmonary hypertension or pulmonary crisis, where you can see actually what is the most important sign when you see in pulmonary crisis. That is actually, hand saturation may be little high and close to 90. Your baby's leg saturation drop up to 70 line. There's a pre and post ductus, that is ductus arteriosus. Pre and post ductus saturation difference is there. You can diagnose like that. Any more questions?
If you all have any more questions, you can. There's another one question. What is confirmatory test to for malrotation of bowel?
Yeah, that's actually, I forgot to tell you, that's a very good question. If you suspect what is called the that's right actually. This is the slides. And how do you diagnose this? Very important, I forgot to tell you. And it is actually upper GI contrast study. Yeah, we give contrast here. Particularly all bilious vomiters, newborns, actually we do the upper GI contrast. We give some contrast, or we just mix contrast with breast milk and feed, and also, or else we put the NG tube and put contrast. And you can see actually where we do the fluoroscopy while we are instilling contrast. We check, screen the baby under image intensifier. You can see where the DJ flexure is. I told you that DJ flexure normally lies pyloric level and left side of the midline and posterior. Whereas here, right side of the midline and low down DJ flexure. So that is diagnostic of malrotations. Because actually these malrotations, because of this large span, they can present as bilious vomiting without volvulus, right? So, I mean, if there's any volvulus, actually you can see abrupt after that actually contrast is not going. But actually without volvulus diagnosing is the most important thing. They can, be presented to you with the bilious vomits. Do the contrast study, DJ is here, and not that level, so we go for corrective surgery. We don't wait until volvulus develops. Very good question. That's another question. We confirm physiological jaundice to prevent future brain damage. Prophylactic mean we give actually phototherapy when this question is for pediatrician actually. I don't involve for these radiotherapies, connectors. I involve jaundice when it is direct bilirubemia, biliary atresia, Phyloic and all. These they are talking about is this is the physiological jaundice. It is indirect bilirubin is rising. And as you said, correctly said, connectors should be prevented. We don't give prophylactically. When the level is high, we do always blood levels. When the levels are high with the nomogram, we start phototherapy, single, double phototherapy, then actually we might have escalating to exchange transfusion like that. I hope that would be the answer. And, as far as I am aware. No, we don't do testicular. No, if it is viable. Can't we salvage undescended testes in late in life? I haven't discussed that topic actually, undescended testes. Undescended testes, it is another kind of important topic. And if I answer your question directly, usually after 12 years, we assume that testis is not working if it is undescended. If we found testis in the inguinal canal or abdomen, so after 12 years, we think we usually start after 6 months. Testicular function when it is undescended start to reduce. Testicular function, leading cell functions, and the spermatogenesis all reduces after 6 months. When it is reached 12, so we all the centers recommend that testis is not working, but the malignant risk is there, and we excise. But usually, if the testis is in good size, I do a biopsy before or frozen section before taking the testis out. It is malrotation. Malrotation happen as a fetal development actually. Presentation wise, actually presentation bilious vomiting is the commonest presentation, or intermittent pain is the intermittent abdominal pain is the commonest presentation. I would say close to 90% present first year of life. Of that also 90% is first month. But I have seen actually, recurrent abdominal pain. What is happening with the abdominal pain in malrotation is twisting and untwisting. Just twist here, untwist spontaneously. So pain relief, just like that actually. Some school kids are presenting like that. So if there's any bilious vomit, so you have to take it seriously. That's a question. Neonatal condition that needs immediate surgical referral. Anal atresia? Yes. Intestinal atresia? Yes. Right side dilatation of pelvic system. That is PUJ-like structure. Not really urgent. Meningomyelocele urgent. Yeah. So this anal atresia, yes. I don't know. Immediate mean what is the thing they are expecting immediate, particularly if this is in the peripheral hospital, yes, these all immediate except pelvic system. But, anal atresia, it is blocked. It is an emergency. You have to do a colostomy. Intestinal atresia, again, it's blocked system. So we have to anastomose, we have to make the continuity. So it is an emergency. Right side dilatation of the pelvic system, just a one side only. If it is a bilateral, I would say that makes the reason actually this option tells that one side only, right side only, and this is not an emergency. So you can refer this patient into surgical clinic. Whereas meningomyelocele, so that can rupture. So that should be referred as soon as possible. So I think other than this fourth one, all true.
It looks like there aren't any more questions. If
Yeah.
you all have any questions, you can type in or you can unmute and ask.
Yeah. You can ask. Yeah, you can unmute and ask. Yeah.
Seems like they don't have any more questions.
Yes, yes, and this is not a good time also.
Yes.
And yeah, meanwhile, if you come across any questions, just put a message into my WhatsApp or Viber, that previous number, and then time is allowed, I try to answer. How do we correct meningomyelocele surgically? Basically, this meningomyelocele is kind of a one condition of spina bifida, also called there's another name for that, and it is actually lamina, posterior lamina is defect, and there's a meninges are protruding out, and so basically what we do is actually repair the defect, and we dissect the dura and put the spinal structures in and close the defect. So, yeah, it is an surgical emergency definitely, because it can rupture and leak, infection, myelitis, and the meningitis. Those are the situations, and better do that. But sometime actually I don't know whether you have that, you ask this question because that you might see some meningomyelocele kids are just roaming around the hospital and not doing anything. It is actually, there was a period, good old days, meningomyelocele with a, lower limbs are not working and no anal tone. No point of managing those patients actually. That was the good old days teaching or the way of management. And some neurosurgeons practice that practice still. And but actually now world has changed. Actually, even developers got that part of management, way of management, meaning the myelocele. And yeah, some centers actually, if low limbs are not working, they don't do anything and let the baby to die with infection and all. And those babies actually, once go home, go to a practitioner and start some antibiotic. If that actually don't get infection, and they live sometimes few months. And but it's a very old technique of management. I think it's 1960s. It was a management in Europe. I don't know whether that idea was there, whether you saw a child just moving here and there with meningomyelocele. That may be the reason. Any more questions?
Looks like
Yeah.
there aren't any questions.
Yes. Yeah. Thank you very much for your
In the absence of
participation.
any further questions.
Yeah. Yeah. Thank you very much for your participation
Yes,
and enthusiasm. And if I get a chance, I'll come and meet you again. And you are welcome to my ward anytime, clinics, theaters, and all. So, what do you have to say, Kaushik?
Yes, sir. Yes, sir. Thank you very much for taking the trouble to prepare this lecture and carrying out this lecture, this very informative lecture on pediatric surgical emergencies, because some of these conditions I don't think like we regularly see unless you work at specialized pediatric surgical center, but when you're working in the periphery, you should be able to identify these conditions and know when to refer them.
Exactly.
So thank you very much once again for taking your time to carry out this lecture.
No problem.
And I would also like to thank the Council of PeMSAA and the President of PeMSAA, Professor Tushara Kundagammana, for providing this opportunity to carry out this lecture series. So then we'll call it a day. Thank you very much, everyone.
Thank you very much. Thank you very much for your participation. Thank you, PeMSAA.